Hi, my name is Neil Frick. I'm Senior Vice President for Medical Programs and Information, and I'd like to welcome you all to this recorded version of Gene Therapy, Real-World Experiences and Current Challenges. This was a medical track session which took place live on August 18th, 2023, during the National Bleeding Disorder Foundation's recent annual conference in National Harbor, Maryland. I have the distinct pleasure of introducing Dr. Ulrike Rice. Dr. Rice is the director of the Pediatric Hemophilia Treatment Center of St. Jude Children's Research Hospital in Memphis, Tennessee. She's also a director of clinical hematology and was one of the site investigators involved in the early gene therapy trials for hemophilia B. Dr. Rice's talk is entitled Impact of Gene Therapy for Hemophilia on Care Delivery in the Hemophilia Treatment Center. Dr. Rice.
Thank you so much, Neil, for the introduction. And good afternoon to everybody. I'm so glad you're interested in this topic, and I hope to share very useful information with you. I have nothing to disclose related to this topic. The learning objectives for these presentations are as follows: to describe the universal guiding principles for providing gene therapy for persons with hemophilia, to examine the multiple practical aspects required for gene therapy implementation within the model of the HTC, and to recognize the important role of communication and collaboration between the HTC team, the person with hemophilia, and the internal and external multidisciplinary providers and stakeholders in order to achieve a successful outcome of gene therapy for each person with hemophilia who will receive it. You all are very aware from previous and other talks that recently two vector drugs for gene therapy for hemophilia have been approved. Etranacogene dezaparvovec, with the brand name Hemgenic, had its FDA approval in November 2022, and first persons with hemophilia in the US were treated in June 23. Valoctocogene roxaparvovec, or Roctavian, was approved just this year in June, and also EMA approved, as well as the other product. This one for hemophilia A, I'm not aware if any patients have been treated with the commercial product to this point. When we engage in this topic and in providing gene therapy, we do need to remember that several additional AAV vector products are still in clinical trials, and also alternative gene therapy approaches are being developed in clinical trials. Offering AAV-mediated gene therapy in the HTC should be seen as an expansion of the comprehensive care which we provide within the HTC care model. The HTC care model exists for 50 years or even more, and is well shown, and there have been a lot of information and data published to be the best delivery service and setting for hemophilia patients to receive their care, and similarly, gene therapy belongs into that picture. I would like to refer to one very significant publication, the MASEC guideline number 277, which was published in May this year on the HCC preparedness for delivering gene therapy for hemophilia. This will give you an enormous amount, a very nicely organized amount of information on how to approach it for your center. And there are other publications I have listed here already, which will be repeated later, and a couple more will be added as well. My goal is to provide you information and resources on how to approach the expansion of the comprehensive care of your HTC. But first, I would like to state the universal principles we should be guided by for introduction of gene therapy for people with hemophilia. First, that person with hemophilia should be at the center of the decision-making on receiving gene therapy, also on planning the whole process. Second, we need to ensure equal opportunity and access for all. We should pursue long-term success and benefit for the person with hemophilia at all times, in all discussions, in all planning meetings, and provide gene therapy within the care model. there are multiple components to consider, and I have divided them up into 7. First, the person with hemophilia, such as considering the patient cohort, education and guidance. Second, the overall feasibility for my HTC. How do I approach a decision to offer gene therapy for hemophilia locally? How do I decide that? Third, knowledge. It's very important to create the knowledge and capacity within the HTC team and the related stakeholders and involved stakeholders. Fourth, what is the infrastructure and staff and multidisciplinary team like at this point, and what expansion does it need to serve providing gene therapy? How does the gene therapy product need to be handled? And we need to develop a treatment plan with the schedule and the process starting from the shared decision-making to screening for eligibility to infusion and the short-term and long-term follow-up. And last, we all should contribute to research in any of the centers. Is it an infusion center or a follow-up center? So the best is to write out a project plan or develop a project plan together with the whole team. This could be a QI improvement project. We establish a core team, a team lead, a gene therapy program coordinator, so that there's a central contact, a central person who oversees the process. Developing a roadmap will be helpful to actually execute the plan which is being discussed. And then you add to that standard operation procedures, guidelines, guides, and tools you can develop yourselves, or one can pull from published material. And there's a lot available already. And last not least, it's very important from the beginning to consider the communication and regular communication with internal and external stakeholders, but also, for example, with the regional or national HTC community, in order to support your knowledge the best way you can and to pull other people's experiences or knowledge for doing the best for our patients. For the first point, education and guidance should be provided to the whole group of persons with hemophilia, not only but of course also to the individual person with hemophilia. This will provide equitable information and discussion opportunities. And apart from having one-on-one sessions, consider small group events which will increase the dialogue or offer and provide the opportunity for a different reflection. Consider a multi-step process. Patients should at least have 3 or more conversations about gene therapy before engaging into the decision-making for it. And we can include various team members from our provider team, not only doctors, but also nurses, a social worker, or psychology, and provide different perspectives within the educational process. Regarding the information we need to provide, think comprehensive. A patient will receive this and has to run with this for the rest of his life. So we need to explain and provide everything, the good and the bad, and provide a reasonable understanding of how much chance I have of the good, or how much chance there is potentially of not so lucky result, potentially shorter durability or failure of the procedure as well. But all of this includes the eligibility criteria, the drug mechanism, how it's being administered, also unknowns or the long-term implications we know about or potentially we don't know about at this point, but we need to make a patient aware that that will be found out over time, and the person with hemophilia who has received it will be part of that process. Of course, a person with hemophilia would like to see the comprehensive care plan, for example, a table with the list of evaluations, how frequent, how long does it take. And last, I would like to point out that we should think about a targeted guidance to people who don't have access to it right now, or who are not eligible for gene therapy products right now, that they could be potentially eligible for the same or for similar product in the future, and how they would work towards that. And for example, sustain their joint health or other health aspects until that time comes. There are many tools and resources already available and published on different websites by the NBDF, the WFH, ISTH, or others. There are tools such as the Adult Psychosocial Assessment Template, now available for gene therapy, developed by the Social Work Working Group of the NBDF. Another tool is the Shared Decision-Making tool by WFH, available on the website. Second component, the HCC decision to consider offering gene therapy. First, I recommend to think big picture and look at my own person with hemophilia cohort. How many patients do I have overall, and how many might potentially be eligible, as I can see by chart review or by people who have contacted us and asked us about, can I be part of gene therapy? If it's only one, it's a different question than if I have 20 participants. And then what is the capacity currently of the HTC for dosing? Or should I rather consider to be a follow-up center and have the patient referred to a different center for infusion, come back for follow-up and be a follow-up center? In this process, it is advisable to include the institutional leadership early in order to get the support, even if the details are not worked out yet. The third component is looking at the knowledge increase for the HCC team institutionally and maybe beyond. We should consider that that person with hemophilia who will have had gene therapy will get in contact with our multidisciplinary collaborators, with the institutional medical community, but we also need the institutional medical community to support what we're doing in our center. And the patient may also get in contact with later with the primary care provider or other community health providers, such as in emergency room. So these are all considerations which can be included, and some of this work, of course, needs to be prioritized because we cannot do everything at once. A whole number of educational outlines and guidelines are published on websites listed here. And if you don't catch a picture of this slide, it is in the MESIC guideline published in May 2023. To develop the capacity of my HTC to expand to provide gene therapy or to provide follow-up for a person who has had gene therapy, determine a team lead and a gene therapy program coordinator, again, to have a central contact, a central person who has the overview over the process and the project. The provider team should at minimum include physician, nurse, social worker, and likely a psychologist, a hepatologist, even if these are not at the institution, potentially from external. The specialists can be from an external institution. We need a scheduler. We potentially still need, we still will need the physiotherapist involved and potentially others. Of course, the pharmacy and pharmacist is important for handling the vector product. Fourth, the laboratory is important to notify and to work with that factor levels will be needed with certain assays and at a certain frequency. And you would like to know about the turnaround time so that that can be used for monitoring the patient after the treatment. Anti-AAV antibodies are required for some products, so some of the information will be product specific and has to be considered and worked in the schedule and in the program. They might not be needed, and they are potentially done with the company or in other specialty labs. That has to be determined specifically to each product. Liver ultrasound and elastography is require or is helpful to have for monitoring before and over long term after for the patient. But these are the basic evaluations. which have been used in all clinical trials and should be used for monitoring the patients. In addition, interdepartmental extra-institutional communications and collaborations should be established, specifically having a hepatologist involved for pre-evaluation and for potential follow-up eventually. It might not be needed, but it will be helpful to have somebody knowledgeable and know that they're part of this team. And think about the also the communications collaborations to set up with a hub center or with the follow-up center if you're a hub center or if you're an infusion center. I put intensive care in parentheses because I think it's hardly needed, but there have been allergic reactions with the infusion reported, and what we've done, we've informed our intensive care that we're doing it today, and that might be helpful to be prepared, but it's hopefully hardly needed. Last, consider the physical location and the clinic space and the other infrastructural capacities which need to be in place for going through the treatment plan. The vector product or biologic can have its own plan. We need to procure it from somewhere. There need to be an order and a prescription, a pre-authorization, and a payment reimbursement plan put up front. There are different payment models discussed in various forums in the literature. I'm not going into further details in this talk because this will be a separate talk, and much of this work and approach is still in development in the different centers, in the different states we have, and the different insurance arenas we have. You will need institutional approval, potentially from a pharmacy and therapeutics committee, to be able to get this drug into the institution and the pharmacy. For the pharmacy and the providers, a operating procedure for receipt, handling, storage, reconstitution or dilution, and preparation for administration and waste management of the product will be needed. And this is probably product specific. Some products may have to be stored at -60 to -80 degrees Celsius. Others may be coming in at room temperature. Last, we need the infusion protocol. This is, again, probably product specific. In the trials, generally, the approach was to give it is a peripheral vein infusion for all these AAV-mediated products, but generally it has been given over 1 hour, and there were a certain number of observation time afterwards in order to look for any allergic or immediate reactions to the drug being given. But other than that, there wasn't any major problem, and there's no major other preparations needed to be done, and typically a patient was followed outpatient after the treatment. The treatment plan will include the following: screening, the infusion, the vector infusion protocol, short-term and long-term monitoring. For screening evaluations, I recommend to think in multiple steps. After sufficient discussion with the person with hemophilia and going through a process of shared decision-making, at some point, a first step for screening needs to be done because some of the tests may eliminate a patient immediately. One way could be to only do anti-AAV antibody testing if that's required for a specific product, because if it's positive, the patient will likely not be able to receive the product. The next step would be full HMP, CPC, CMP, typically viral studies, and the liver ultrasound with elastography. And any other additional evaluations might be product specific. Pre-vector infusion evaluations I've listed here in order to have some baseline labs available just on the day of infusion in case the patient has an allergic reaction, so that you know where the hemoglobin is and where the chemistries and the renal function were beforehand. The vector infusion protocol I explained already. Right after the vector infusion, we call it a short-term monitoring time to see the patient once or twice per week for about the next 6 months or 4 to 6 months for monitoring factor levels and liver function. Typically in Many of these AAV-mediated products, there is a risk for vector-induced transaminitis, which has been treated either try to be prevented prophylactically with the use of corticosteroids such as prednisone or prednisolone, or has been treated with on-demand prednisone. This reaction has been observed at a time frame between about 2 weeks after the infusion up to like 4 months, potentially a little later as well. Therefore, and what might happen with a very slight ALT elevation is that the immune system responds to the vector having transduced liver cells and therefore destroys liver cells which harbor the gene. Therefore, your factor expression may go down and will not be recoverable. Therefore, this short-term monitoring is very important to decide upon. Do we monitor once or twice per week? What is the experience with these products out from the clinical trials or maybe from other now commercially treated participants? And how do we want to handle that? Best to be planned up front. If steroids are used, this therapy has to be monitored. There are side effects such as hypertension, hyperglycemia, weight gain, or potentially depression or manic response to the treatment, depending on the dosing and the length of treatment. And with that, the importance of psychosocial care around the whole treatment comes to light a little more as well, and should be considered to be established before and throughout and during the short and long-term monitoring for the person with hemophilia. Long-term monitoring then after about 6 months can change to monthly evaluations, and then after 1 year, roughly, the clinical trials have changed to monitoring patients at every 6 to 12 months. In the long term, it is important to look at liver health, monitor factor levels for persistence and durability, monitor and document adverse events, monitor, document any unknown toxicities, and communicate these with our hemophilia community and the scientific community, as well as pharma community, and consider the continuation of psychosocial care as indicated per each participant. Last not least, component 7, research contribution. Since we have observed patients who have been successfully treated with AAV-mediated gene therapy for anything between 4 to 6 years up to 10 to 12 years, we don't have long-term outcome experience. Some patients have been treated more than 20 years ago, didn't have sustained factor activity, but did receive the gene therapy drugs, and we have experiences from them as well. So far, we don't have any very significant adverse outcomes identified over the long term, but we don't know. There are many unknowns, and we have the responsibility, together with the persons with hemophilia who got treated, to collect the long-term outcome data. At best, lifelong, continued, regular, throughout the comprehensive care, and documented in a chart. And of course, the best would be if all patients who were treated sign up for the national or the international gene therapy registry studies as mentioned here. So in summary, implementation of hemophilia gene therapy and its impact on the HTC will be possible and will be there and have an impact. It's a change, but it is an addition to the already existing comprehensive model we have in each HTC, be it smaller or be it larger. What it will require is expanding the knowledge, the capacity, create pathways, look at the reimbursement and payment ways. And it requires effort, but it's also very exciting. And it will be bringing so much positive experience to our patients. Therefore, patient centricity, again, as my last sentence, is key for our success. And I thank you so much for your attention.
On behalf of the National Bleeding Disorders Foundation, I would like to thank you, Dr. Rice, for your willingness to be a part of this year's Gene Therapy Medical Track session. And thank you very much for this excellent presentation.